is the premium received upfront before the commencement of the policy? Who underwrites the premium? Where is it being lodged? And if the policy is running into losses, because it's the community which is running the scheme, basically what I understand. So they are sharing the risk. Initially the premium may be 1,000, so the policy may be at some profit, or it could be at a loss. So how are we managing the profitability or the loss part? That is one question. The second question would be, perhaps we are talking of people who are capable enough to give the premium as well as to pay for their treatment cost, especially for the indoor treatment cost, because you are working on the reimbursement model. Otherwise, the statistics clearly show that if we are talking of the bottom of the pyramid people or the micro health insurance concept which we are talking of, that they have to sell their belongings, at times their houses or animals, to get the treatment done, just to pay to the hospital. So that was the point which was also being raised by Dr. Suresh. So maybe your inputs on that.
Regarding the first question, the money that is collected is 100 rupees per person per year as a premium, against which there is a coverage of 15,000 rupees per person per year coverage, hospitalization coverage. The money is collected upfront before the incidents happens, and it is in bank accounts which are managed by community representatives. It's not on the bank account of Uplift. So that's one part of the question. Second part is what you say, there is nothing against us. The problem is that, yes, we know there is a burden which happens in upfront payment. In urban communities and the referral system that we have created, you have to look at the context in which we are working. We started in urban areas. People say, urban areas are better. There are hospitals, rural mein to milte nahi hai. So when we started, the basic question which I said was, people said, I will pay for you telling me the right doctor, the right treatment, the right cost. Because they don't understand the concept of insurance. So the entire logic that we have understood today, after working for 8 years, and that's not much, I feel. We are still progressing. As I said, we started with 300 women. Today we are 1.3 lakh people. So the question here is that, yes, whatever you have said is completely right. There is no argument against it. But what so happens in urban areas also is that because our rural presence is not that much, which we will be doing this year, is the fact that there are some 2,000, 3,000 rupees available with them immediately. And what we have brought in is a referral system, whereby when you fall ill, call the helpline, 24/7 helpline, and there is a doctor behind it who will tell you that the nearest 5 hospitals are like this. This will be the cost. So if you are a very poor person, there is a trust hospital or there is a public hospital. If you can still afford, there is maybe a higher level hospital. So we give options. And depending on your paying capacity, you can take a public hospital. Now you will say you're diverting people to our public hospitals. What we have done is we have tied up with social workers in public hospitals. Many people do not know that social worker in a public hospital is a very important person. And once you direct it to the social worker, you can be assured that the treatment will be there. It will not be just like that. So for us, the question, it's a trade-off today. That, whether you want to do cashless and increase the cost of premium, because it will happen. The moment, yes, what you're saying is right, but for me, when we look at what is not available today is some kind of protection at the end of the day. So if I do cashless, my premiums become unaffordable. And we are very clear on that. It's something which we have studied for last 4 years. And in fact, what we are we are now piloting what we call a health loan facility. Give out a loan. Immediate loan, without asking anything, just give a loan, because it's a loan. If it gets converted into a reimbursement, fine, otherwise it will continue as a loan. That's something which we are piloting, but I agree to you, and there is a trade-off we are doing right now. We have seen experiences where people, after starting cashless, are now going back to reimbursements. So we have seen those experiences very closely. And as I said, the challenge is much more at a macro level. We are in a medical jungle. India is a medical jungle. I work with 5 doctors, but frankly, the way I've seen doctors cutting the poor pockets, it's scary sometimes. So in that sense, being a reimbursement model, the hospital has no interest in, upping the charges basically, or the patient asking OPD to be converted into IPD because he has to pay from his pocket first. So that's a trade-off we are doing, and maybe once we have the adequate numbers, we will go for cashless. Today we don't have that kind of critical size, which is around 0.5 million to 1 million.